Welcome to the Obert Lecture, Diabetic Ketoacidosis in Pregnancy. We're going to be talking about this topic because it doesn't come up very often and the consequences are pretty significant if it's either unrecognized or treated inadequately. So it makes sense to periodically go over this in detail. The key learning points, in my opinion, are the fact that early recognition of DKA is important. And the reason for that is that maternal and really fetal morbidity and mortality are very high in untreated or inadequately treated DKA. The other thing is that DKA may occur at relatively low glucose values, delaying the diagnosis. And that delay in diagnosis, obviously, is the thing that complicates early recognition. The next thing is the fact that the treatment of DKA is very slow. It's a very gradual process. It has to be slow for a reason, which we will talk about. And lastly, the other thing you need to remember is that delivery in the unstable patient may be catastrophic. And we say that all the time about a lot of things. Delivery of an unstable patient may be catastrophic, but I would like to get into the details, the physiology of why that would happen. This lecture essentially is a physiology lecture, and it deals with nutrition or just the use of fuel. And for the most part, what we're talking about is use of glucose as the form of fuel. It's your appetite that makes you go and seek out fuel. And that fuel is taken in, and then it's stored, and then that fuel is used between feedings to maintain your energy needs. Pregnancy, for the most part, is the same as non-pregnancy, except that there are extra needs for the growing child, and after delivery, extra needs for lactation. Basically, you need to supply a steady fuel supply to the brain. The brain is a metabolically active tissue that is always requiring fuel, so you need to have a constant supply of fuel for the brain. And for the most part, in most people, glucose is the preferred fuel. Now, when you eat, what happens is you break down the proteins, the fats, the carbohydrates into the smaller building blocks of amino acids, fatty acids, and glucose. And those are absorbed in those forms. Well, once they get into the bloodstream, they need to be stored. And they are stored as protein, triglycerides, and glycogen. By storing them in all these intracellular depots, what that does is it keeps there from being large shifts in the osmolarity. So if the osmolarity of the blood is basically how much in the way of solute or particles is there compared to the amount of water, is it very concentrate or is it very dilute? But the bottom line is osmolarity stays within a very narrow range. And if all the stuff that you just ate and absorbed in all those amino acids and triglycerides and glucose so far, if you don't move it into the cells, the kidney's going to get rid of it. That's what the kidney does. The kidney senses that the osmolarity is too high and it will get rid of extra solute. The thing is that in the process of getting rid of the extra solute, water goes with it. The kidney can only get rid of things in water. So even though water wasn't the intended goal to get rid of, it's going with it anyway. All right, so now you've eaten, you've stored it, and immediately you still have energy needs. So basically the glucose that has been stored as glycogen, and it's mostly in the liver and skeletal muscle, and glycogen is really just long chains of glucose. So you can store more glucose if you link them all up together. It takes up less room, and it's a dense form of storage. But as soon as you stop eating, you need more glucose into the bloodstream for all the cells to use. So it turns right around and the glucose flows out of these cells, muscle, liver, primarily liver, and is available for all the other cells to use. Now, over time, glycogen stores will start to get depleted, but in the process, they will supply this nice steady supply of glucose until you eat again. Metabolism during starvation. And if we just define starvation as a long time between feedings, what happens is the glycogen stores are down by about 15% after 24 hours of not eating anything. So obviously, after 24 hours of not eating anything and you're only down by 15%, it kind of implies there's a fair amount of storage that has happened. The other thing is the liver has the ability to produce glucose not just by breaking down glycogenolysis, it has the ability of forming glucose out of something else, like amino acids. And that's called gluconeogenesis, making new glucose. So what it does is you break down the protein of muscle, you take those amino acids, take off the amino group, rearrange it, and there you go, you have sugar. And glycogenolysis and gluconeogenesis are two ways the blood sugar goes up, even though you're not eating. And our patients are always baffled by that. They never understand how it's possible that they could have a blood sugar of 130 in the morning when they haven't eaten anything for 12 hours. Well, that's where it comes from. You break down the stuff that you've stored and you make new sugar out of amino acids. All right, metabolism during prolonged starvation. Well, prolonged starvation, obviously, a very long time between meals. And the initial use of glucose by breaking down glycogen and producing sugar from amino acids starts to decrease. And what happens is you have a shift from glucose as the primary fuel to fat. So that hepatic glucose production decreases and hepatic ketone bodies increases. And the way that happens is adipose stores fat. And when you break down those triglycerides, that is called lipolysis. So basically you free up these free fatty acids that came from triglycerides, and then they head off to the liver for ketone body production. And ketone bodies are really free fatty acids just chopped up into little tiny pieces, 2 carbon pieces like that. And ketone bodies are the only other fuel besides glucose that can be used by the brain. So, which includes acetone, beta-hydroxybutyric acid, and acetoacetic acid. So those are the 3 ketone bodies that are found in humans. And those are the only other types of fuel the brain can use besides a glucose molecule. So if you haven't eaten for 7 days, the serum concentration of the ketone bodies is sky high. All right, well, what is it that makes the shift over to starvation metabolism? Well, there's either true starvation, there's no glucose entering the body, you're not eating, or there's perceived starvation, glucose entering the body but not entering the cells. Insulin is the thing that's responsible for getting the glucose into the cells. And if you don't have an insulin effect, you don't get the glucose into the cell. And lack of insulin effect is either because there truly is no insulin, an absolute lack of insulin that you would see with type 1 diabetes where there's no residual beta cell function, or you can have plenty of insulin, but you have insulin resistance, meaning the cells just don't respond to normal or even high levels of insulin. And examples of insulin resistance arise because of obesity, infection, and hormones, etc. And what will happen is you will stay in this starvation metabolism, which is continued burning of glucose at a low level and increased burning of fat by way of ketone bodies. And that will keep going until you either end the true starvation by eating something, or you end the lack of insulin effect, meaning you get some insulin or overcome the insulin resistance somehow. And otherwise, you'll die eventually because of lack of fuel. All right. The DKA, diabetic ketoacidosis, I guess in its simplest form or simplest definition really is it's an alteration in metabolism due to a relative lack of insulin. And that relative lack of insulin includes both categories, absolute and resistance. So absolute would be a type 1 diabetic who is not feeling well, loses her appetite, and then stops taking her insulin because she's not eating. I'm not eating, I didn't take my insulin. Or an example is not an intentional one, it's an unintentional one where a type 1 diabetic has insulin pump failure. That results in an absolute lack of insulin. And then the other way is insulin resistance, where you have this new level of insulin resistance, presumably from like an infection. Infection tends to increase insulin resistance. So if you've already got a couple layers of insulin resistance, like pre-existing insulin resistance from obesity, and then you add the pregnancy hormones, cortisol, somatic human placental lactogen, any of those things, you add another layer of insulin resistance, and then you get a third one, like a pyelonephritis, that can put you into DKA potentially. Well, if you've got a relative lack of insulin, there's an inability for the glucose to get into the cells. If the sugar's not getting into the cells, those cells perceive that there's no glucose available. So some cells have the task of responding to that. And that includes the pancreas, the adrenals, the pituitary. So you get this outpouring of counter-regulatory hormones like glucagon, also from the pancreas, catecholamines and cortisol from the adrenals, and growth hormone from the pituitary. All of those have a counter-regulatory effect, and they try to bring the blood sugar up. They stimulate glycogenolysis. They stimulate gluconeogenesis. And that's good, that the counter-regulatory hormones are there to bring things up. The problem is they have the potential to make an already high blood sugar even higher. So if you have a blood sugar, counter-regulatory hormones make it go higher, you get even higher hyperglycemia, and that hyperglycemia results in osmolarity that's higher in the blood. And as we said before, that's not tolerated. The kidney says, nope, can't have it that concentrated, need to get rid of some of it. So what happens is the sugar is dumped out into the urine, and it takes water with it. And anytime you have an increase in urine output because of a heavy osmotic load, that's called an osmotic diuresis. So that's what starts happening if you don't have insulin. You have high blood sugar, the kidney responds by getting rid of it, but water goes with it. So you have massive water loss, followed by hypovolemia, and when you have hypovolemia, you have decreased tissue perfusion. So if you have 7 liters of blood or that's circulating, and suddenly or gradually that goes down to 4, well, there's going to be poor tissue perfusion, and there can be renal failure because the kidneys are among the tissues that are not perfused. All right, so that first part, the hyperglycemia, is really the first part of DKA, the D, the K, and the A. And that D, diabetes, was the hyperglycemia. Now we'll talk about the ketosis portion, the K. Well, if there's a lack of available glucose, I'm not saying there's a lack of glucose, I'm saying there's a lack of available glucose, meaning there's plenty in the bloodstream, but it can't get into the cells. So as far as those little cells are concerned, there's no glucose around. And there is a shift from glucose as the primary fuel to ketone bodies. So basically, you've been shifted over to this starvation metabolism because of a lack of insulin effect. Now, the problem is that these ketone bodies that are produced by the breakdown of fat, although they are good for providing fuel for the brain, they do have a bad side effect of the fact that they are strongly acidic. Beta-hydroxybutyric acid and acetone are very acidic. And what they end up doing is consuming available bicarb. Your serum bicarb starts at one thing, and then when you start producing acids because of this, it consumes it. And whenever you produce acid that consumes bicarb, that is called a metabolic acidosis. Additionally, in addition to having acidic nature of these ketone bodies, they also are osmotically active, just like glucose molecules. So ketone bodies also cause osmotic diuresis. So you already had water loss, dehydration, hypovolemia started. This makes it even worse. So now your tissue perfusion is dropping again. And when you have a decrease in tissue perfusion, you switch over to lactic acid production. When you have plenty of tissue perfusion, that means there's plenty of oxygen delivered to the tissues, and they use the process of aerobic metabolism or respiration. So where you take glucose and it ends up in carbon dioxide and water. But if you don't have oxygen, it goes to anaerobic metabolism, which ends up in metabolic acids being produced, like pyruvic acid, lactic acid, things that are called metabolic acids, as opposed to CO2 and water, both of which are handled very quickly by the lung. All right, so you've got this metabolic acidosis that's forming now as a result of the ketosis. The acidosis, is because of the metabolic acidosis that's going on. And whenever you have acidosis, you're producing lots of hydrogen ion. And whenever there's lots of more hydrogen ion in the bloodstream, your pH is going down. 7.4 to 7.3 to 7.2 to 7.1. And those hydrogen ions, now there's plenty of them. What they do is there's so many of them, they kind of drift on into the cells. And every time a hydrogen ion drifts into the cell, it bumps a potassium out. Well, the potassium now that used to be in the cell is now outside the cell in your serum. And there's this osmotic diuresis going on. And during that, there is a depletion of many electrolytes, a whole bunch of things: sodium, potassium, phosphorus, magnesium. A lot of things are getting dumped out into the urine at this time. This is decompensation. And decompensation is really where the things that are going on are not helpful. They're a consequence. It's not helpful to become acidotic. It's not helpful to become severely dehydrated. They are a consequence, and they make things worse. So dehydration, hypovolemia, that's a consequence. It's not helpful. In fact, it makes the acidosis worse because it decreases tissue perfusion. The symptoms of DKA include malaise, lethargy, because of dehydration, and there's not a lot of fuel to be used. There's also polyuria and polydipsia. So if your osmolarity goes up in your bloodstream, your kidney's going to respond by trying to get rid of it, polyuria, and you're going to be extremely thirsty, so you're just going to want to drink fluid all the time, and that's the polydipsia. Another symptom is tachypnea, specifically Kussmaul breathing, and what that is an increase in rate and depth, and that is a compensatory respiratory alkalosis. So the other things may not be compensatory, but this one is. So if you've got a metabolic acidosis, this response by causing a respiratory alkalosis keeps the pH from dropping precipitously. The decreased skin turgor, hypotension, tachycardia, all related to the low blood volume. And then fever may be a symptom, but which is not specific to DKA. It's really indicative of a precipitated infectious etiology like a pyelonephritis. Now, to make the diagnosis of DKA, you need three things. You need the D, you need the K, and you need the A. And the reason for that is that the treatment of DKA is different than the treatment for not DKA. You have to have all three of those things going on to indicate that you've gotten into this really bad cycle of decompensation. You can have one or two of those things and not be in that cycle, and therefore the treatment is not the same. So, to meet the criterion for D, or hyperglycemia, you have to have a glucose that's at least greater than 180. Now, usually it is over 300, but it only needs to be over 180 to count. Next, for the K, you need ketosis, and it can either be a serum beta-hydroxybutyric acid, 1 to 2 or greater, or it can be a 3 or 4 plus dip on urine with dipstick. For the acidosis, you either need a gas, either venous or arterial, of less than 7.3, or you need a serum bicarb of less than 15. Now, I had said that DKA can occur at lower blood sugars, even normal blood sugars, but rarely. But apparently a third of DKA in pregnancy occur when the mean blood sugar is less than 200. So, why is that? Well, the fact is that pregnancy is a state of insulin resistance. You've got these hormones, so you've already got some insulin resistance. 2, the pregnancy is considered a state of accelerated starvation, which is a lot of the glucose is being taken away by the fetus, resulting in a need to switch to fat burning. So ketone production from fat burning is very commonly higher in pregnant patients. We see that all the time. You dip their urine on a good day and it's, +1. So we know that ketone production is already going on. And then the last thing is, the thing that keeps people from getting acidosis is having lots of bicarb around to neutralize that. But what has happened is there's a maternal respiratory alkalosis that started way back in the early part of the pregnancy. Early in pregnancy, in the first trimester, progesterone stimulates the brainstem and the respiratory drive to increase respiration. And that causes a respiratory alkalosis. So primary respiratory alkalosis has started a long time ago. And that's a good thing. And the reason, well, not the reason, the value of that is if you have a respiratory alkalosis and the pH has gone up, that's very good for a little baby inside who needs to unload all the acid that it's producing. If the mom's pH was 7.3, well, the baby can't really get any better than that. But if the mom's is 7.45, that's good for unloading acid. So that's good news. The problem is that mom's bicarb stores have been depleted. She has a primary respiratory alkalosis, so there's a little bit of compensation by getting rid of bicarb. So basically, when it comes to the slippery slope to DKA, pregnant patients just have a head start. They already have some ketosis going on. They already have a little bit of compensatory metabolic acidosis going on to make up for their primary respiratory alkalosis. So they have a head start. So they just don't need to be in this cycle for as long as everybody else. All right. So how do you make this diagnosis of DKA? Well, I said you need the D, the K, and the A. And the presence of acidosis and ketosis and hyperglycemia all together is a state of decompensation. And the acidosis and the ketosis are the things that are going to cause the physiologic downward spiral that'll end in death if it's not interrupted. You got to treat it early. You got to recognize it early. And the reason is that there still are mothers that die from this. And even more frightening is the fact that fetal mortality from a single episode of DKA is still 10 to 25%. So that's a huge deal. If a mother goes into DKA, there's a 25% chance that the baby's not going to survive it, even though the vast majority of mothers will survive it. The other thing, again, delivery during DKA to save a fetus greatly increases the maternal mortality. I'll explain why. But fixing the mother is the way you fix the fetus. In general, we tend to think of a baby who looks bad on the monitor as having a lack of oxygen. But when it comes to DKA, there is not a lack of oxygen necessarily. It's a decrease in the maternal pH, causing a decrease in pH of the baby. And if you can bring the moms up, there was no problem. There was no abruption. There was no preeclampsia. There wasn't something choking off the oxygen supply. She just has a lower pH, and therefore the baby has to have a low pH and will look not so good on the monitor. All right, let's talk about treatment of DKA. First, let's talk about the treatment of anything. Well, supportive therapy is generally, it's not related to the actual disease itself. Doesn't matter what it is. Supportive therapy really means that the body is a machine, and it's got these multiple mechanisms of self-repair. So the immune system eliminates bacteria, viruses. It also heals tissue. The coagulatory system just stops blood loss. All these things kind of take care of itself. And if you just keep the body functioning well as possible, it'll take care of itself, and you don't need to do anything specific. And that's what it is most of the time, whether you have a common cold or you scratch yourself or cut yourself. You don't have to do anything. It'll take care of itself as long as you're generally healthy and functioning well. So things that fall into this category are oxygenation, normovolemia, normal electrolytes, make sure the clotting factors are normal, and provide fuel. The supportive therapy is very important because it's these secondary perturbations, these counterproductive things like high degrees of fever, high degrees of dehydration, high degrees of hypoxia. Those are the things that may kill the individual before the mechanisms of repair kick in. So yeah, that's it. Supportive measures just counteract the counterproductive responses and allow self-repair. Specific therapy is when you actually go for the primary cause rather than the secondary perturbations. And almost always you do specific therapy in conjunction with supportive measures. So you would really never treat a bronchitis with antibiotics only without telling them to rest and take fluids and take Tylenol for fever. You do them together. An example of specific therapy is removing a perforated appendix, antibiotics for a pneumonia. And in the case of DKA, the specific therapy is insulin. When you treat DKA, you have to do both. Supportive therapy alone doesn't work, and specific therapy alone doesn't work. The acidosis, the poor tissue perfusion, they'll kill the fetus and the mother. And the primary cause, or the relative insulin deficiency, isn't going to fix itself. And the evidence for that comes from the pre-insulin era, where over a 74-year period, they followed 172 patients, which is not very many patients, in the hospital that takes care of all the diabetics. The premier diabetic hospital in the country only took care of 172 in 74 years, and the ones that they took care of, a quarter of them died. Well, really what has happened is that back then there was no insulin. So if you didn't have any insulin at all, you just died. You didn't go to the hospital. The people that made it to the hospital had some degree of insulin production. So if you don't have insulin, there is no replacement for that. All right, so the specific therapy when it comes to DKA is intravenous insulin. And since insulin resistance is part of the problem, treating infection is another way of specifically treating diabetes, DKA. So broad spectrum antibiotics would count as specific therapy. And then in general, the supportive therapy is correct these massive volume deficits. And we're talking 100 milliliters per kilogram. So if she's 80 kilograms, she's down 8 liters of water. Correct potassium loss. The potassium loss approaches 300 milliequivalents. And then correct the acidosis. Now, you rarely have to do that with bicarb. If you correct the other things, that'll just follow along. When it comes to giving insulin, you have to give it intravenously if someone has DKA. If you give subcutaneous insulin, if there will be poor tissue perfusion, and that subcutaneous dose of insulin that you gave will be sitting right under the skin an hour later. You have to give it intravenously. And again, you have to make the diagnosis of DKA before you give insulin IV in this dose. Because if she doesn't have DKA, she just has a high blood sugar but nothing else going on, that can be catastrophic by dropping her blood sugar. Well, what's the difference? What's the difference between 350 and DKA and 350 blood sugar and no DKA? Well, the big difference is that with DKA, there is this machine turned on producing glucose, gluconeogenesis, glycogenolysis, and ketone body production. All the fuels needed for the brain are turned on to be produced in very high levels. So even if you give a big dose of IV insulin, which lowers the serum glucose value, it is quickly replaced by this other stuff that is being pumped out. But if she just has a high blood sugar and nothing else, because she hasn't had a high blood sugar for very long, you can clear out the blood sugar, leaving her with nothing left, and that can be, fatal. The goal here is to give insulin, and generally it's 10 units. It's really 0.1 unit per kilogram. So if she's 80 kilograms, then that would be 8 units. But probably it's easier to just remember 10 units. That's a good dose for everyone who's truly in DKA. And then you're going to follow that with an infusion of 0.1 units per kilogram per hour. So if she's 70 kilograms, that would be 7 units per hour. The goal is to lower the glucose very gradually. That's hard for us. We like to do everything quickly. We like to get it taken care of, get this whole thing fixed before shift change, but we can't do that. And the reason we can't do it is because if you rapidly decrease the serum osmolarity, let's say she's got a blood sugar of 550 and you immediately get it down to 90. Well, that sudden decrease in osmolarity means that compared to your cells, your serum is very watery now. So before you started treating it, you have very concentrated blood with a high osmolarity, and all your cells have lost water too. So your little brain cells and your liver cells and your skin cells, everything has shriveled up and lost water. If you suddenly turn your serum into Kool-Aid, all that extra water is going to go rushing into all the shriveled up cells everywhere. And that's okay in your ankle and you get edema and your fingers swell up, but it's not okay in your brain because your brain's in a box, the skull. And if you have cerebral edema, that alone can cause seizures and encephalopathy. But since it's in a closed space, it can go on to cause herniation of the brainstem and respiratory arrest. All right, so we know that we need to go slowly. We know that the deficit in fluid, specifically water, is about 100 milligrams per kilogram. So we've got the average 70, 80 kilogram person comes in, they're 7 to 8 liters down. And ultimately, our goal is to fix that. But we have to do it slowly. So the way you start is by giving isotonic saline, normal saline, 0.9% saline. 2 liters over 2 hours. If you'd use a hypotonic solution like half normal, again, you're putting Kool-Aid in that has a lot of free water that can just go zipping into the cells very quickly. If you use normal saline, it won't do that, and there'll be a very gradual equilibration between the serum and the cells. Now, once the glucose drops below 250, you switch over to half normal saline. And the reason for that is now you're not going to have a precipitous drop anymore. And two, if you keep giving normal saline, you're going to get sodium overload and a metabolic acidosis. So you can't keep doing that forever. 75% of that 7 or 8 liters needs to happen in the first 24 hours and 25% in the following 24 hours. So right there, that's hard for all of us to comprehend, that we're going to try to fix this person over the next 2 days, when really we like to fix everybody in the first couple hours. But we're just going to have to realize, nope, we have to go slowly. So 75%, that's 5 liters the first day, and 25%, the other 2 liters, the following 24 hours. Well, when it comes to potassium replacement, what happens is, while the potassium was out there in the bloodstream, the hydrogen ion knocked it out, the potassium went out into the bloodstream, and while it was out there, the kidney dumped a lot of it. So you've actually lost a bunch of your potassium. Your total body potassium is down because the kidney dumped it in the toilet and you can't get it back. Also, there's going to be insulin given, which accelerates the movement back into the cells. So, and that's why we use insulin for treatment of hyperkalemia. It causes a shift of potassium into cells. So insulin's causing the movement inward, and you're correcting the acidosis. So now those hydrogen ions are slowly coming out, and potassium's heading back into the cells. So you have these 2 different ways potassium's leaving the bloodstream and going back into the cells. And then what'll happen is your potassium in your bloodstream will drop. So you need to replace potassium. You know that you lost about 300 milliequivalents, but you have to do that very slowly also, because if you do it too quickly, then you have hyperkalemia, and that causes problems, dysrhythmias, etc. So no more than 20 milliequivalents per hour is how fast you're going to do it. And then when it comes to treating with bicarb, very rarely is that needed. Really just correcting volume that results in tissue perfusion is good. You don't need to do anything further. If their pH is down in the 6s and they're going to go to an intensive care unit, they very well may start a bicarb drip. Here's an algorithm of how to manage diabetic ketoacidosis. And the reason I put this slide up with all this stuff on it is I do want to emphasize that it is very complicated. There is an algorithm that changes as you're treating it. So I don't want to make you think that diabetic ketoacidosis is very simple and very easy to treat. But I do want you to see that you can tear away most of that stuff and realize that still you've got at the top IV fluids, insulin, potassium, and maybe bicarb. Again, here's another fairly complicated algorithm from Baha Sabai. And when you strip away most of it, you can see that really the main things are fluid replacement and insulin therapy. All right, to summarize the DKA treatment in pregnancy, you have to hurry up and get started fixing her very slowly. Recognize it early, but you have to treat it very gradually. Step 1, assess the patient. Initiate monitoring, check vital signs, put on the fetal monitor, just check pulse oximetry, put in a Foley. Do the history and physical, and that's important that you can still do your history and physical, that there is time. It's very important that you do this, even if you're multitasking by ordering labs, starting IVs, putting on oxygen, and so forth. Getting the history and physical is important because you want to, first of all, make sure you have the right diagnosis. There are other things that can present like this in diabetics, including drug overdoses and so on. So the main thing is do your history and physical. There is time to do that. Gain IV access, put on the oxygen, and move her to the ICU if she's in hypovolemic shock or respiratory failure. Those are even more uncommon. So most of the time it'll be probably done in triage. Step 2, after evaluating her, see if you can make the diagnosis of DKA. And to make that diagnosis, again, you need the D, the K, and the A. So the diabetes or the hyperglycemia just requires a blood sugar over 180. For ketosis, generally a beta-hydroxybutyric acid greater than 1 to 2 counts. So that's a serum test. But also, you can use a 3 or 4 plus ketones in urine, which frequently is a faster way of doing it. And then lastly, there has to be acidosis, either by a arterial or venous blood gas showing a pH less than 7.3, or a serum bicarb less than 15. And if you have all 3 of those, then you have DKA. Step 3, if she's got DKA, then begin the treatment for DKA immediately. That means normal saline. Remember, we don't want to use a hypotonic solution. So that's 1 liter over the first hour, 1 liter over the second hour. Next, insulin, and you're going to give 10 units regular insulin intravenously. Sub-Q will just sit there wherever you gave it, because of poor tissue perfusion. And then that insulin bolus is to be followed up by an infusion of 0.1 units per kilogram per hour. So a 70 kilogram person would start at 7 units per hour. Often it takes a while for that to get up to us from pharmacy, but the 10 units of insulin, go ahead and push that IV if she has DKA, not if she doesn't have DKA. If she just has high blood sugar and some ketosis, she does not get intravenous insulin. And that is basically it for the first 2 hours. So just knowing what to do for the first 2 hours is really the goal here, which is 2 liters of normal saline and 10 units of IV insulin. Now, in phase 1, basically the D, the K, and the A will all potentiate each other until the patient dies. If you give insulin, what you're doing is you're turning off glycogenolysis. Insulin is a storage hormone, not a release from storage hormone. So, if you give insulin, it tells the liver to stop breaking down glycogen, stop making new stuff from amino acids. That's the gluconeogenesis. And if you can turn off those 2 things, then you will stop increasing the osmolarity. And it's that osmolarity that's causing the massive fluid loss because the kidney's trying to get rid of it. So give insulin, turns off those things, osmolarity stops going up. Next thing, insulin turns off ketogenesis. You're burning your fat, you're producing ketones. Ketones, again, also raise the osmolarity. Additionally, they are weak acids themselves. So you're increasing the acidosis when you burn or produce ketones. So giving insulin, again, turns off release of energy. It's a storage hormone. So basically it tells the ketogenesis to stop and stop burning fat. And then the fluids, the really important part, increase. The fluids will correct the hypovolemia. And once you've corrected the hypovolemia by giving fluids, you've increased tissue perfusion. And when you do that, you move back to aerobic metabolism, not anaerobic, so you decrease lactic acidosis. So the other thing fluids do is they slowly decrease the osmolarity and prevent further fluid loss. So with insulin and fluids, You've interrupted the death spirals. Phase 2. Really, for phase 1 was that really the first 2 hours. Phase 2 is slowly continue to fine-tune over the next 24 hours. As we said earlier, you're down about 300 milliequivalents of potassium. It moved out into the serum, and while it was in the serum, it got dumped in the toilet, and you can't get it back. So you're going to have to replace it. And on the next slide, we'll kind of go over some guidelines. Prevent hypernatremia. If after you've given 2 liters of normal saline, it's time to switch over to half normal. And then you have to correct that hyperglycemia very slowly. So even though we'd like it to be the sugar to go from 500 down to 100 as fast as we can, just so we'll know if we fixed it, we can't do that. We have to go slowly. Our goal is really no more than 50 to 70 for the first hour. So if you check it, it was 500 and now it's 450, that is good. Even if it's 550, the second hour, that's fine. You've given the insulin to turn off the glycogenolysis and gluconeogenesis, and you've initiated fluids, most important part. When the glucose gets down to less than 250, you can add dextrose to keep there from being any overshoot from your insulin. And then really what you're going to do is correct the volume deficit over the next 24 hours. So you've got a long time to fix this. You acted quickly in the first 2 hours. Now you have plenty of time to look it up. Pull it up on the computer, pull it up on your books, whatever. Get it all in front of you. Figure out what you're going to do over the next 24 hours. You have time. The potassium replacement, in general, we're trying to replace the 300 milliequivalents of lost potassium. There are some guidelines to that. Obviously, one is you're not going to replace it all at once. You're going to go slowly. Now, depending on where someone is in DKA, when there's acid production and it moves into the cells and potassium moves out into the bloodstream, the potassium's high at first. And then over time, as that potassium is lost, then the serum will drop. So you may have a patient in DKA who has high potassium, or it may be low. Either way, you have time to check. So check the potassium before you make your final decision about what to give. Fluids, you can just go ahead and give them. But when it comes to the potassium and insulin part, wait for the potassium. So if it's greater than 5.5, hold the potassium. Just give the normal saline. If it's 3.3 to 5.5, go ahead and just give 20 milliequivalents. And that category is really the biggest category. So for the most part, you're going to be giving 20 milliequivalents per liter. If it's in the borderline range, 3 to 3.3, go ahead and give 40 milliequivalents for that first liter. And if it happens to be less than 3, hold the insulin. Because if it's 2.7 and you give a bolus of insulin, it's going to drop the potassium even more quickly into the ones. So hold the insulin. All right, I'll repeat myself like I do a lot, which is the diagnosis of DKA is urgent. Fluids are urgent. Insulin is required, but not urgent. So you have time to check the potassium. If it's up in the 5s, don't give potassium yet. If it's down in the 2s, don't give the insulin yet. Meanwhile, try not to deliver the baby. And this is a lot easier said than done. When you're looking at a terrible strip, particularly if you're looking at a terrible strip in someone who's full term, it can be very tempting to just get this baby out. All right. Well, couple things you need to know. One is that in general, when we see an acidotic baby, it's because there's a lack of oxygen to the baby. And in that lack of oxygen, the baby moves over to anaerobic metabolism and becomes acidotic. In this case, the baby is not acidotic because of a lack of oxygen. It's acidotic because the mom is acidotic. And if you can fix the mom's acidosis, the fetal acidosis will resolve. So right there, that's the main thing. Fix the mom, the baby will be fixed. The other thing you need to keep in mind is that delivery is a sudden loss of volume in an already very volume depleted patient. And if you do that, if they're already down 7 liters of fluid, which means their blood volume is down a liter or two also, they run the risk of getting renal ischemia, myocardial ischemia, cerebral ischemia. So acute kidney injury is not uncommon during this, but having a myocardial infarction or a stroke is also possible if you suddenly take out another liter or so in the delivery process from someone who's already low. The other thing is that correcting or preventing the volume loss can cause major osmotic shifts. So if you want to tank her up on the way to the OR with a lot of fluid, that also isn't allowed, because if you give a lot of fluid over a short period of time, there's going to be cerebral edema. So you can't do that. That's something we do in our regular patients all the time. Tank them up on the way to the OR, run the right IV, and so forth. We can't do that with the DKA patient. All right. So one, if you either try to prevent volume loss or you have volume loss, you're going to cause a problem. So in both those cases, the maternal morbidity and mortality are greatly increased. The other thing is that you run the risk of delivering this severely acidotic baby who didn't need to be delivered. And an acidotic baby, particularly metabolic acidosis, is a baby that's very hard for the neonatal team to resuscitate. An acidotic baby, because of a high CO2, respiratory acidosis, you just bag them and you can quickly get rid of that acidosis. But metabolic acidosis, not so easy. So if it's full term, you can still deliver this severely acidotic baby that'll have a difficult resuscitation. But what's really concerning is if you panic, deliver a 25-weeker who's severely acidotic and severely premature, and the baby could have been resuscitated in utero. Here's a slide showing some late decelerations and in the top screen, followed by resuscitation of the mother, which resulted in an improvement in the baby's status. And then the strip at the very bottom is a case of a 34-weeker who had late decelerations and was taken for an emergency C-section, and the baby came out with a very low pH of 6.85, very difficult resuscitation. That would probably have been better served by resuscitating the mother. And again, this decision to hold off on delivery of the baby really can save the mom some significant morbidity and mortality. Now, when that changes, when you would avoid delivering a baby because of maternal morbidity and when you would actually go ahead and deliver the baby is very difficult. The main thing is she needs to be normovolemic. So probably the first 2 liters need to have gotten in, but she needs to be as close to normovolemic as possible. Now, most of the time, just that process alone reverses the acidosis and the baby starts to look better. But the idea is that 8 hours later, after you've replaced the mom's lost blood volume and the baby doesn't look very good, well, that is a mother that can tolerate delivery, and maybe it's true that the baby is acidotic for another reason. The take-home points. 1. Pregnant people are different from non-pregnant people. And the difference is, which is the respiratory alkalosis, the starvation ketosis, and insulin resistant just makes her more likely to get DKA because she already has a head start. Problem is that the differences also may delay the diagnosis, particularly because the sugar can be lower, making people not suspicious of DKA. For the treatment, the take-home points are always fluid, always insulin, always antibiotics, almost always potassium, and rarely bicarb. You've got to recognize it as early as possible so you can get started, because the baby may not survive the secondary perturbations of DKA, and the treatment is gradual, so you have to get started as soon as possible. Thank you for your time.